Good afternoon. I am Anna Johnson, and I'm going to talk to you about how to do a basic nursing head to toe assessment. So, before you get started, you are going to want to remember who you are and why you're there. As the patient's nurse, you are there to support that patient, not just medically, but also emotionally, also their comfort, and you're there to advocate for them within this medical system. And you want to be the best part of that patient's day. So you want to be a friendly, encouraging, cheerful nurse who is there to meet the patient's needs. You're going to start by washing your hands because the last thing that patient needs is a dirty nurse bringing infection into their room that you gathered somewhere else. Now you're going to introduce yourself and tell the patient why you're there before you start shining lights in their eyes and poking their tummy and all these things. And in doing that, you're going to show your patient honor that you value them, and you're going to ask the patient to introduce themselves before you start looking at their urine and examining them. So it'll be something like, "Hi, I'm Anna. I'm your nurse today. The first thing we're going to do is your head to toe assessment. Can you tell me your first and last name? And can you tell me your date of birth?" And you're going to take that first and last name and the date of birth that the patient tells you, and you're going to compare it to the wristband. And that way, not only are you making sure that you are treating and documenting on the right patient, but also you're able to assess already that patient's orientation, and you're already listening to what's going on with them in their speech and their understanding of the situation. General appearance part of the assessment is pretty organic. You've already started doing it as soon as you started talking to the patient. You were able to figure out if they spoke English or not, or you're able to find out what their preferred language is. And when they talk to you and you just kind of ask them some general polite questions, you can assess their tone and clarity and pace. For example, tone, are they monotone? Do they sound drowsy? Clarity, are they slurring their speech? Are they able to enunciate? Do they seem confused? Is it taking a little while to gather the words that they're looking for, or are they having flight of ideas and speaking really fast and you can't slow them down, which would tell you a little bit about what's going on mentally with them? And is their speech appropriate? Do they Are they able to appropriately answer your responses, or are they just kind of someplace else mentally? And their posture, when is the patient slumped over and looking uncomfortable but not strong enough to help themselves? That tells you a little bit about what's going on with them in their musculoskeletal system. Are they sitting up? Are they laying down? Are they just on their way back from the bathroom? When you look at their gait, are they able to walk evenly? Are they steady? Do they need support? Um, and what kind of fall risk are you gathering that they are? And as soon as you walked into the room, you actually already started your neuro assessment. Your basic assessment includes a level of consciousness and their orientation. So when you walked in the room, were you able to see if they were asleep or awake? That's step one. If they are asleep, are they full on in a coma where you can't rouse them at all? Or are they able to wake up and become alert just by you talking to them? Or do you have to like pinch them to get them to wake up? And what about orientation? Were they able to tell you their full name? Are they able to tell you where they are, what month of the year it is, and why they're in the hospital? Next thing you're going to do is take the patient's vital signs. The reason you do this next is because if you notice that something is vitally wrong with your patient, you need to intervene before you continue their assessment. So if you see that the respiratory rate is 25 and blood pressure is 180 over 90 and heart rate is 140 and your patient says that their pain level is 10, you need to intervene and take care of that pain before you move on. If the respiratory rate is 4 and the blood pressure is 90 over 50, you're going to need to intervene before you continue your assessment. So core temperature here is 98.6 oral. Um, that it's often a little bit lower for women. I think that this is more of a standard for men. Also, it'll be 1 degree lower if you're taking an axillary temperature and 1 degree higher if you're taking a rectal temperature. So 97.6 axillary and 99.6 rectally is the same thing as 98.6 orally. Heart rate should be between 60 and 100. Respiratory rate should be 12 to 18 breaths. Might be faster if the patient is in pain or has a fever or is working to breathe. Might be slower if the patient has respiratory suppression. Maybe the patient's on too many pain meds or something like that. Blood oxygen should be about 95 to 100. It should only be lower really if the patient has COPD, and then the normal value is about 88 to 92. And blood pressure should be about 120 over 80. So after the vital signs, we're going to find out if the patient's in pain. If your patient's pain is an 8, it's not a good time to do your head to toe assessment. You need to manage their pain before you move on. So here is one example of a pain scale the Wong-Baker faces. This is helpful if you're working with a patient who has language barriers or if you're working with a child. And we know that pain is what the patient says it is, when and where the patient says it is. So for one person, that one stimulus could be a 2, and for another person, the same stimulus can be an 8, and that's just how it goes. When you find out what the pain number is, next you're going to go through the old CARTS questions. So you're going to ask about the onset, location, duration, character, alleviating and aggravating, radiating, timing, and severity. So for example, when this pain comes, how quickly or slowly does it come on for onset? Location, where is it? Oh, it's in your shoulder. Duration, how long have you had it? Oh, you've had it for a year? Oh, you've had it just since yesterday when you had a fall. And the character, is it stabbing? Is it dull? Is it tingling? Is it numbing? And all of these different characteristics can give you an idea of the origin. Muscles tend to be more aching, right? Nerve pain might be more tingling. Alleviating and aggravating. So what sort of things make it feel better and what makes it feel worse? Okay, so it hurts more when you turn to the left side. It hurts when you raise your arm, and it feels better when you ice it, for example. Um, Radiating, does it start in one location and drift to another location? And timing, does it hurt every morning? Does it hurt just with movement? And of course, the severity is the number on the pain scale. When we look at the patient's skin and nails, we are going to basically we kind of do this throughout the whole assessment, but basically you're going to start with the extremities. And just when you talk to your patient, you're going to notice what's going on with their skin, right? Their body's covered in it. You're looking at the color. Does it look kind of yellowy and jaundice? Does it look appropriate for their race? What about when you touch them? Is their temperature cool and clammy? Does it feel hot? And what about moisture? Is it dry and flaky? Are they sweaty? Um, or are they very oily? And that might show some hygiene issues. This is not only are you figuring out the skin, but this also tells you a little bit about their neuro history or what kind of patient care they're getting in the hospital. So for example, when you look at this patient's legs, you would notice that their skin below the knees is dark pink or purple. It's dry, flaky, and they have some wounds. And what's that going to tell you about this patient? That's going to tell you that this patient has chronic venous insufficiency. So you can tell a lot by looking at the patient's skin. And then when you look at your patient's nails, are they clubbing? That's when the nails are really flat and the tip of the finger is really wide, and that shows, and it's kind of spongy feeling, and that shows chronic hypoxia. So that would be if a patient had heart issues or lung issues. And then capillary refill. When you pinch their fingernail, you're looking at how quickly the color returns to normal after it blanches, and you want that to be at less than 3 seconds. And so when you look at your patient's skin, you're getting an idea of what's going on in their cardiovascular system and their pulmonary system and their neuro, right, if they're able to take care of themselves. Okay, so now we've established that your patient is stable enough and um, that their pain is under control enough for you to continue this assessment. Head to toe assessment, let's go to the head. We're looking at head, eyes, ears, nose, and throat. When you look at your patient's head, you're just going to put on some gloves and get right in there looking in their hair. You're going to see they if their hair is really oily, if they have a dry, flaky scalp, if there's any infestation, if there's any skin breakdown, especially for your patients that lay in bed all day, make sure that they're not getting a pressure ulcer back there. Um, and also, are there any kind of smells going on? Does this patient, you need to mark down that they need a bed bath? Um, can you smell the patient's breath and you find out that they've been in the hospital for 2 days and no one ever gave them a toothbrush? Help them out. Make a note of this and come back and help them out. Um, from the head, you're going to look at their face and you're going to see whether or not it's symmetrical or whether it looks like there's some kind of palsy or there's been some kind of stroke. You can see this if one eye is drooping or if one side of the mouth is drooping lower than the other side. Also, is their nose symmetrical or does it look like it's been broken at some point? And then you're going to spend some time on their eyes. First, we're going to look at their pupils. Are their pupils, this is Perla, are their pupils equal, round, reactive to light, and accommodating? So pupils should be the same size, otherwise there's been some kind of brain injury. And then are they round or do they look squashed? Also, are they reactive to light? So pupils should be probably between 1 and 5 millimeters wide. If their pupils are all the way constricted, you're going to need to dim the lights for this next bit of the assessment so that they can dilate a little bit. And what you're going to do is you're going to flash your pen light in one eye, let's say flash your pen light in the left eye, and you want to see that pupil constrict at least 2 millimeters. So if there are 3, you want them to go down to a 1. If there are 5, you want them to go down to a 3. And the same thing should happen with the other pupil that's not getting the light flashed in that one. So they should be equal. They should have the same actions at the same time. And then you're going to shine your pen light in the other one, let's say the right, and make sure that you're having symmetry and the same things going on with the left pupil as is going on with the right. And then you're going to see if they have accommodation in their pupils. So you can hold something, an object, it could be your pen light off instead of shining on them, or just your finger about a foot in front of their nose. And you're going to slowly move your finger towards their nose and see if their pupils can accommodate and track what's going on, or if they kind of have to lose their grip in a way and aren't able to trace it all the way back until they're cross-eyed. And then you're going to look at extraocular movements. This is EOM. So you're going to take something like your pen light or your finger, and you're going to tell your patient to face you, keep their head still, and to just move their eyes. And you want to see if they can move their eyes to all 6 of these cardinal fields without any extra movements. So we would call that nystagmus if there's kind of like shakiness or like quaking of their pupils. Also, when you look at your patient's eyes, you want to see, is there any drainage or exudate? Are their eyes really dry and red? Is their sclera nice and white and shiny, or is it looking yellow and jaundice? And if you pull down their lower eyelid, does it look nice and pink under there in that little capillary bed, or is it looking really pale or really red? And then you're going to move on to the patient's ears. And when you look at the ears, you want to see just generally, how do they look? Do they look normal? Do they look dry or cracked? Do they have any wounds? Is there blockage? And you're going to go ahead and palpate and see if you feel anything weird, any little nodules or anything like that. You might notice some tophi in your patients with gout. Is there any tenderness? Does it hurt them when you touch their ears? Does one side look really red because the patient's been lying on that side all night and no one came in to move your patient? Um, and then you're going to go to your patient's nose. And we already talked about symmetry. If their patient looks like they've had a broken nose, well, can their patient breathe easily out of their nose, or is there blockage in one side? If you close one nostril, can they breathe out the other nostril, and vice versa? Um, If you get your pen light and flashed around in there, do they have drainage? Do they look really red and sore in there? And are they able to smell? If you do something like have your patient close their eyes and you open an alcohol wipey and hold it up to their nose, will they be able to recognize the smell of alcohol, or do they have a problem with their sense of smell? And then when we move on to their throat, we're going to start with their mouth. Just looking at your patient's mouth, you can see, are they cracked around their lips, like a patient with a vitamin deficiency, or are their lips just generally dry and cracked? Do they have some kind of cyanosis going on? And then when they open their mouth, what does it look like in there? Is it really dehydrated and painful looking? Is it really bright and beefy red, like someone with pernicious anemia? Use your tongue depressor and just like move it around their mouth. Look at what's going on. Are you seeing some cavities? Do you see old food in there the patient wasn't able to swallow? Is everything equal bilaterally? Do you see some kind of drainage from the tonsils? Um, and are they able to cough? Is their gag reflex intact? When the patient talks to you, do you hear them speak clearly, or do they have like a really dry, raspy voice? Does your patient have any wounds in their mouth, any little sores or ulcers? Um, is it looking yellow in there, like someone with jaundice, especially if your patient has darker skin? This is a good way to assess jaundice. And what about dentures? Does your patient not have any teeth and their dentures aren't present, but then you notice that they don't have a soft tray before them, but instead they have a bunch of crunchy foods that there's no way they're going to be able to chew? If so, you could make the take the appropriate intervention to order them food that they can chew. What about their bite? Are they able to bite? Is it nice and clear and even, or do you hear some TMJ, some clicking or grinding when they bite down? When you're looking at your patient's neck, you want to see, does it look symmetrical on both sides, or does it look like there's some tracheal deviation? Um, do you see any lumps? Do you see any pulsations? And then after you look at it, then you're going to feel it. Here's some little green tracks where you can feel the lymph nodes. Do any of the lymph nodes feel swollen or hard? What about that carotid artery? You should be able to feel it on both sides. Don't assess them at the same time. You can give your patient issues if you do that, but but you should be able to feel their carotid artery on both sides. What about JVD? If the patient is at 45 degrees, can you see the pulsations of their jugular vein because they have heart failure and blood is kind of slow to drain out from their head? You want to be able to notice all these things when you're looking at your patient's neck. Let's move on down the body and go to the chest. So we're going to take off our patient's hospital gown or, just the top half of it. And first we're going to start by inspecting by looking at the chest. And we are seeing if we see any scars. Maybe they've had some heart surgeries that we didn't know about that hadn't come up in the past medical history that we can document. Do we see any lesions, anything weird? Is there some asymmetry? Is the rise and fall of the chest equal on both sides when they breathe? Do they have a big barrel chest? Or do they have that normal proportion? That's going to have to do with the pulmonary system, but anyways, you'll notice it right away when you look at the chest. And then next, you're going to palpate. When they breathe, can you feel that equal rise and fall? Do you feel anything abnormal, any rattling? Any thrills, anything like that. And then you're going to take the diaphragm of your stethoscope and you're going to listen to these 5 points of the heart. We have this mnemonic ape to man that helps us to remember that. We're going to start with the aortic valve here at 1 and move over to the pulmonary valve down to Erb's point, which is halfway between the top and the bottom of the heart, the tricuspid valve, and the mitral valve. And so with the diaphragm of your stethoscope, you should be able to hear if there's any extra lubs or dubs, any adventitious sounds, and then you're going to listen to the same thing with the bell of the diaphragm, and that'll help you hear any murmurs. So when you get to the mitral valve down here, that's going to be where you get your apical pulse, and you're going to listen to that for a full minute. And notice that all of these points where you're going to assess it are not over bone because you can't hear the heart well over bone. Um, and then it's in the intercostal spaces. If the costal means ribs, then you're going to listen to between the ribs. And then if a woman has a breast, you're going to get her to kind of like lift it out of the way so that you're not listening over her breast tissue, or of course, the sounds will be a little bit muffled. Already started inspecting the chest. And while the patient is still facing us, we can go ahead and do our we did our palpation. Now we can go ahead and do our auscultation. And this isn't a great picture. I had kind of a hard time finding a good picture of all the places that you listen to the lung sounds. But if you can kind of imagine combining what's shown here on the front and here on the back, and imagining that those are all the points you're going to listen to on the front. You're going to start high up, even above the clavicles, and you're going to listen to the lung tissue up there. And you're going to start left to right and come down, right, and go over to left. And if you'll notice, the dots here where it shows the back, those are the places where you'll best be able to hear the sounds. So on the back, you're not going over the shoulder blades, you're not going over any bone, you're not going over the spine, and then in the front also, if there's breast tissue, you're not going over the breast tissue and over muscles, but you're kind of getting it at the narrowest point of the chest and back. And you're going to listen in all of these fields for anything unusual sounding, whether it's rails, crackles, wheezes, stridor, or rhonchi, and you'll note where you hear it, and then you can document that and pass it on for further review. Also, you're going to see if the patient has any pain with breathing. Does it take accessory muscles for them to breathe? Is it very difficult for them, or are they able to do it calmly? So then when you listen to your patient's lung sounds and back, you're going to go ahead and take that opportunity to also inspect the back and look for any lesions, any pressure points where you notice that they might be getting bed sores or anything like that. Um, Yeah, I think that that'll do it. So now that kind of wraps up the front and the back of the chest, the heart, and the lungs. To the abdomen. So far, when we've assessed our patient, we started with inspection and then we did palpation and auscultation. Um, we don't do any percussion because you're undergraduate students and you won't be doing any of that. But the abdomen is a little bit different. First, we're going to do inspection, auscultation, and we're going to save palpation for last. Partially because there could be abdominal tenderness, and partially because you can kind of disrupt what's naturally going on in the bowels and get an inaccurate reading of bowel sounds. So inspection, you'll look at your patient's stomach and look for any scars or lesions. Are there any hernias or any bulges? If your patient has a PEG tube or a urostomy or a colostomy, you want to see what that looks like. Does the site look clean? Is everything well adhered? Does it, if they have an ostomy, does it look moist and pink, or does it look dry or really dark or infected? Does their bag need to be changed? If the patient has a PEG tube, do you need to change the gauze that's around it? Is there some residue there? Um, and then you can ask your patient about what's going on with their bowels and their urine. With their bowels, how often are they having a bowel movement? What's the consistency? Is it painful? Basically, is the patient having diarrhea? Are they having constipation? Are they bleeding when they use the toilet? Are they having to strain or to use anything to help them have movements? And then what about their urine flow? If it's a man, if he's having issues with his prostate, he might have a hard time starting that flow of urine. You can ask them if there's stinging in their urine, if they've noticed anything unusual, whether it's clear, whether it smells bad, whether it's really dark. And then you can look at their bag if they have a Foley catheter and see if the urine is clear or cloudy, if it has any debris or residue in it, if it is nice and light colored or if it looks really concentrated. And you can see if that bag needs to be emptied at that time. So we've looked at them, we've talked to them, and now we're going to listen. When you listen to your patient's abdomen, you're going to use the belly button as the center, and then you're going to divide lines up and down to make it 4 quadrants. And in your right lower quadrant, you're going to start listening first with your diaphragm. And then you're going to move to your right upper quadrant, to your left upper quadrant, and then to your left lower quadrant. And in 1 minute, a healthy patient should have 5 to 30 bowel sounds. Doesn't mean you're going to listen to all of these for a minute, but if you listen for 10 seconds and you don't hear anything, it doesn't mean you can say that the patient has hypoactive bowel sounds. If you don't hear anything, you need to listen for a full minute and try to see if you can hear that 5 to 30. Otherwise, the average is about 2 bowel sounds every 5 seconds. And once you hear those, you can listen a little longer to see if it's hyperactive, or else you could just move on. Um, and if the patient's having hyperactive bowel sounds, it could be a sign of obstruction or gastroenteritis. Um, if they're having hypoactive bowel sounds, they could have like a paralytic ileus, and you want to make note of that. Um, Oh, also, I don't know if I talked about with when we inspect the abdomen, we want to see if it's distended. Sorry, I'm going to rewind a little bit. We want to see if the abdomen looks distended. If it's distended, then they can have issues like heart failure, cirrhosis, ascites, or pancreatitis. So you want to write that down for sure. If it's a very thin patient, then you'll say that it's concave when they're laying down, or maybe they have a flat belly. But you want to note the shape of it as the patient's laying down. Is it protuberant if the patient is pregnant? Um, so now that we listened to those 4 quadrants, we're going to listen to the vascular system here with the bell of the stethoscope. And you can listen to a couple inches above the belly button to listen to the abdominal aorta and see if you hear any bruits or if everything sounds normal. And then down here, kind of in your groin on the right and left side, you can assess whether those arteries sound normal or whether you hear any adventitious sounds. So now that we inspected and auscultated, now we're going to move on to palpation. And we're going to do this in the same order. We're going to start with that right lower quadrant, um, and then we'll come up, and then we'll move over to the left upper quadrant, and we'll move down to the left lower quadrant. And we're going to start with light palpation and make sure that the patient's not feeling anything, any pain. Do we feel anything weird like lumps or nodules? Um, and then if we move into a deeper palpation, which will be a couple inches deep, about 2.5 inches deep, does the patient feel any pain when we do that? And make sure whenever you ask the patient if they're having pain that you go ahead and go through that old Cart's mnemonic and find out more information about what kind of pain they're having. So we're looking at the musculoskeletal system, and right now we're going to look particularly at the 4 extremities. And we've already looked a little bit at the upper and lower extremities when we were looking at the patient's skin. And that integumentary assessment is going to continue through all the parts of the body, right? We're looking for skin breakdown and bruises and signs of hypoxia all throughout the body. But right now, we're going to look a little bit more closely at the strength of the extremities. So when you test your patient's hand strength, you're going to put your first 2 fingers together, your forefinger and your middle finger, and you're going to hold them up in front of the patient and say, "Can you please squeeze my fingers as hard as you can with both hands at the same time?" And the patient's going to grip your fingers and squeeze them. And you want to see if that patient's strength is equal on both sides or if one side is weaker. And then you're going to get a general idea of their overall strength. So you'll probably uh, document this on a scale of 0 to 5. 5 would be full strength. 0 would be no muscle contraction whatsoever. The patient's totally flaccid. Um, 3 would be the patient has strength against gravity, but they can't have strength against resistance. So let's talk about resistance. When you assess the patient's arms, you're going to have them do a couple things. You're going to hold your hands up like you're trying to stop them or something, and then they're going to put their hands flat against yours and push against you, and you're going to create resistance, and you're going to see how strongly they can push. And then you're going to ask them to resist you while you push on them. And then you're going to have the patient lift their arms in the air one at a time for about 10 seconds, and you're going to notice if there's any drift or if they can keep their arms up. So, for example, if the patient was able to hold their arm in the air for 10 seconds without it dropping, but they were not able to be strong against resistance, you would mark that as a 3, which would mean that they're strong against gravity but not against resistance. And if the patient just had wasn't able to work against gravity at all, but they were able to move about, maybe squeeze your hand, but they can't lift their arm, then you would mark that as a 2, not strong against gravity. And if they have some strength against gravity and some strength against resistance, then you'd mark that as a 4. And 5 would just be normal, healthy, full strength. Now you're going to use that same scale as you assess the feet and the legs. So with the feet and legs, you're going to put your hands out and have them push on you against your hands like they're pushing on a gas pedal, and you're going to try to resist them. And they're going to see if their feet are stronger than your resistance, if they can push it down. And then their legs, you're going to lift one leg at a time. When they're laying down, you have them lift one leg at a time for 5 seconds and see if they can hold it up there. And that'll give you an idea of whether they're strong against gravity, strong against resistance, or hopefully both. And then you're going to go ahead and evaluate their pulses. And so you can check pulses in different places along their arm and along their leg, but distal pulses are probably the most important, because if the distal pulse, if you're having a hard time finding that distal pulse, you'll work higher and higher or closer to the core, and you should be able to get a stronger pulse the closer you go. So if you answer questions about the distal pulse, then you'll know what's going on all throughout the leg, right? I mean, there's no way that they'll have a pulse in their feet and not have a pulse in their knees. So this is a good picture of how to get the pedal pulse. And then the radial pulse, as you probably know, is just a couple inches below the thumb on either hand, and you want to assess it with 2 fingers, not with your thumb. Sometimes you can feel your own pulse in your thumb, and that can be a distraction. So you just want to use 2 fingers and assess it. And if there's no pulse, you mark that as a 0, and you're going to need to get a Doppler to find it. Hopefully there's a pulse. And if it's a normal pulse, it'll be 3. If it's light or thready, it'll be a 1. If it's weak, it'll be 2. 3 is normal, and 4 is bounding. So like if there's an issue going on, maybe if the patient's blood pressure is very high or their heart's racing or something like that. So with this, you're also going to want to look at your patient's skin turgor. If you pinch their skin, does it pop right back, or is it tenting because they're dehydrated? You're going to look at their color. Is it appropriate for their race? Are they looking, do they have pallor or some cyanosis? Are they looking blue? Are they looking red? Do they look like they have some jaundice? And you're going to see if they have warmth. So if their body is warm and then their toes are cold, then they have an issue with their peripheral circulation, for example. And how's their movement? Do they have any issues wiggling their toes or their fingers? Do they have some minor paralysis issues? What about sensation? So can they feel if you take like a little needle or a broken tongue depressor and you poke them on one side as well as the other side, can they feel the same thing on both sides, or do they have a stronger sense on one side than the other? And are they able to differentiate, for example, the sharp edge of a broken tongue depressor compared to a cotton ball? Are they able to differentiate between whether they feel something soft or sharp? And of course, you would assess that by having them close their eyes, and you would touch them in these different parts of their body on their extremities and ask them, is it sharp or soft? Sharp or soft? And then you can ask them where they feel the sensation. All right, so you've completed your head to toe assessment. You've started with the head, with the hair, and have gone all the way down to the toes. And now, before you leave your patient's room and go do your documentation, you're going to make sure you've met all your patient's needs. So if while you were pushing that on that patient's belly, she felt like she needed to urinate, you're going to help her go to the bathroom. If you notice that your patient has dry mouth and is dehydrated, you're going to go get them some water. If your patient's in pain, You're going to bring that back, that pain medicine. And before you leave the room, you're going to let your patient know that you are following through, that you paid attention to their needs, and that you are going to take care of them right now. And if they don't have any further needs, you're going to let them know when they can expect to see you again. Um, I will be back in 2 hours or something like that. And they will know that they're receiving the best nursing care and that even when you're not right in front of them, you still have them in mind, you know what's going on, and you are caring for them. So thank you. I finished my assessment. Is there anything else you need at this time? I will be back in an hour and a half unless you call me before then, and feel free to. You're going to put your patient's bed rails up. You'll put that bed in the low position so your patient doesn't fall, and you're going to make sure that they can reach their call light. Thank you for joining me today. Here are the references. These are the websites where I got my pictures.